Assalamu alaikum wa rahmatullahi wa barakatuhu. Now, from today, we are going to start our very important topic as far as the subject of pharmacology is concerned, as far as the utility of that group in the clinical side is concerned, that is chemotherapy. So, for that, the first introductory aspect of the chemotherapy is under the title of this General Principles of Antimicrobial Therapy. And today we are going to start with the first part. We have divided for convenience into two parts. This is really very important to understand the general principles of antimicrobial therapy. Now, different aspects we will discuss under this heading, including, first of all, what is chemotherapy? These are the questions. These may be the viva questions, these may be SCQ, etc., etc. So, what is chemotherapy? Then, we will also discuss generalized mechanism of action of chemotherapeutic agents, regarding how we will select or on what ground selection will be done of these antimicrobial, what possible antimicrobial spectrum, their possible uses, what advantages, etc., we get, or what disadvantages may be there with the combination of antimicrobial agents. And also, while we are using these chemotherapeutic agents, what possible adverse effects, what possible complications may be seen with these agents, and especially the most important one is the development of the resistance against these chemotherapeutic agents. Now, chemotherapy. So, basically, it's the use of drugs selectively acting on microbes and parasites present within the body. Microbes may be bacteria, they may be fungi or viruses. Similarly, parasites may be protozoa or helminthes. So, chemotherapy includes all antimicrobials, antiparasitics, or anti-cancers. Remember, chemotherapeutic agents, they may be, as I told you, antibacterial. So, these antibacterial further may be of two types. They may be antibiotic in nature and non-antibiotic in nature. So, antibiotic means those antimicrobial agents which are derived or which are get from the living organism, like from fungi, etc. Examples are penicillin, cephalosporins, etc. While the non-antibiotics, which are not get from the living, or rather they are from the non-living things, that is, they may be chemical in nature, synthesized within the lab. For example, sulfonamides, etc. So, after antibacterial, these chemotherapy agents may be antifungals against the fungi, antivirals against the viral infection, antiprotozoal includes antimalarial, antiamoebics, and anthelmintics against worm infestation, roundworm, tapeworm, pinworm, etc., and the anti-cancers. Diagrammatically, whenever there is invasion of the infection, say for example, bacterial infection, so immediately immune defense system is activated against that bacterial infection. Now, these antibacterial drugs, usually we need an ideal nature. So, ideal antimicrobial may be which is selective against the specific infection, specific against the bacteria, and that antimicrobial should be very powerful, should immediately kill the bacteria or the viruses, the fungi, etc., etc. and their toxicity should be only against the bacteria and almost should not be any toxicity against the human cells. So obviously ideals are rarely seen and rarely we can get anti-ideal antimicrobial agent. Now regarding the classification of antibiotic, that may be based on the chemical structures, their mechanism of action, antimicrobial spectrum, or regarding safety also. Chemical structure means we have separate structure of the beta-lactam antibiotics which contain the beta-lactam ring in their structure, or there may be acrylamides in nature, there may be tetracycline, tetra, 4 ring molecules there, so on. Similarly, mechanism of action, we will see later on whether they are 50S ribosomal subunit inhibitors or 30S ribosomal subunit inhibitors, or they are acting as a DNA, RNA, etc., etc., or they are destroying the cell wall or the cell membrane, etc. Antimicrobial spectrum against the gram positive or gram negative, there may be against the bacilli and the cocci, etc., etc. And regarding safety, we will see what is the therapeutic index. Now, we can also make them groups according to the activity, whether they are killing or just blocking the further division of bacteria. For example, in this diagram, we have inoculated some bacteria in a petri dish containing specific agar. After 24 hours, we have seen that without any antibiotic, there is multiplication of those bacteria. If we put the bacteria, so after 24 hours, there will be no growth, rather all the bacteria have been killed. This is the bactericidal effect. They kill the bacteria. And because they act only if bacteria rapidly divide. While bacteriostatic may be there, they don't allow further growth, but they put a static activity against those bacteria. So stop the bacterial division. Regarding therapeutic index, there may be high therapeutics, low and very low therapeutic. What is therapeutic index? Yes, it's the margin of safety of a drug, which usually calculated how much dose is required to produce the therapeutic effects and what dose will produce the toxic or lethal effects. Okay, so high therapeutic index means they are highly safer in nature. Penicillin, vancomycin, macrolides, etc. With the low therapeutic chlorphenicol, cephalosporin, tetracycline. And very low may be polymyxins, aminoglycosides, and emitters, B, etc. Now, antimicrobial spectrum of the drugs. Usually there are targets for the antibiotic. There are mainly two targets at the level of entrance inside the cells of the bacteria, the fungi, or the viruses, etc., cancer cells, or there may be internal sites present, targets present inside the cells. At the entrance, there may be cell wall or the cell membrane. These may be the targets. Or internally there may be ribosomes, or there may be DNA material, etc. Now, regarding the targets of the antimicrobial agents, these agents inhibit either bacterial cell wall or bacterial membrane. So, they can inhibit the cell wall synthesis, or they may increase the permeability of the membrane. So, then obviously if there is increased permeability, so different bacteria or other materials or other agents may go from outside inside, and from inside they may come outside. So no protective membrane is there. Second is, these antimicrobial agents may inhibit the protein being synthesized inside the cells, or they may inhibit the metabolic activity which is usually going on inside the cells, or they can inhibit the nucleic acid synthesis. So these are the four basic targets against which these agents act, and they inhibit these targets. Now, in this diagram, let's see the mechanism of action of antimicrobial agents. Inhibitor of cell wall. For example, beta-lactam antibiotics, vancomycin. These are the two which inhibit the cell wall synthesis. Second, there may be protein synthesis inhibitor, tetracycline, aminoglycoside, macrolides, clindamycin, chlorophenicol. Inhibitors of the metabolic activity, sulfonamides, trimethoprim. They inhibit the conversion of paramagnetic benzoic acid into tetrahydrofolic acid. There may be inhibitor of the nucleic acid function or synthesis, like fluoroquinones, rifampin. And lastly, although it should come at the second number, but regarding the importance as far as their use clinically is concerned, inhibitor of cell wall function, permeability, isoniazid, amphotericin B. So, with example, these are the 5 basic cell wall and cell membrane we have separated now. Now it has become 5 in nature. In the previous slide, there were 4. So actually they are 4, but for your convenience, we have divided into 2: cell wall synthesis inhibitor and increased permeability. Now, first, bacterial cell wall synthesis inhibitors. As I told you, beta-lactam antibiotic, penicillin, cephalosporin, and other non-beta-lactam antibiotic, but they inhibit the cell wall synthesis, cycloserine, vancomycin, bacitracin. Increasing the bacterial cell wall membrane permeability, polymyxins, including amphotericin B, which is actually antifungal, nystatin, that is also antifungal, isoniazid, actually is an antitubercular. Protein synthesis inhibitor, inhibiting the synthesis of the protein inside the cell. For example, interfering with the 50S ribosomal subunits. Now remember, usually all are bacteriostatic in nature, all these 50S. Chlorophenicol, macrolides, clindamycin, lincomycin. Macrolides include erythromycin, clarithromycin. So usually all are bacteriostatic unless specific condition. They may show, however, bactericidal effects also, but usually we see their activity as bacteriostatic. Second group, drugs which inhibit the 30S ribosomal subunits. So this may lead to cell death, that is bactericidal effect. So aminoglycosides, tetracycline. Now aminoglycosides may include streptomycin, gentamicin, kanamycin, tobramycin, amikacin, etc., etc. And tetracycline, again, they are usually bacteriostatic, but they also show very strong bactericidal activity. Antimetabolites, because mainly there is synthesis of folic acid which is being inhibited by the drugs, so that is why they are also known as antifols. So they compete with the paramagnetic benzoic acid for the enzyme dihydroxyurea synthesis. So there is actually sequential blockade of the pathway of the pyruvate synthesis. Here the drugs include sulfonamides, pyrimethamine, trimethoprim, etc. They inhibit this enzyme. Inhibition of nucleic acid synthesis. So they may block the action of DNA gyrase. For example, rifampin or rifampin DNA dependent RNA polymerase. So there is inhibition of the bacterial RNA synthesis, especially the quinolones and fluoroquinolones. Fluoroquinolones commonly known as ciprofloxacin, ofloxacin, levofloxacin, etc., etc. There may be some factors which affect the selection of antimicrobial agents. How we can select the antimicrobial? Number 1, selection depends upon the tissue penetration. How much the drug molecule of these antimicrobials are able to penetrate the tissue. in different body tissue compartments, at the site of infection, at other sites, including brain, etc., eye, lungs, so many other compartments. Then another problem, formation of biofilms. These biofilms are actually the colonies of slowly growing bacteria or fungi, etc., which are enclosed within an exopolymer matrix. These colonies are grown up on the prosthetic devices present inside the body. They may be prosthetic valves of the heart, there may be other organs, etc., and the joints, etc., so artificial joint replacement. So any prosthetic devices. So on these usually these bacteria or fungi may form biofilms. So due to formation of this exopolymer matrix, they restrict the access of these antimicrobial agents which are intended to target the sites. So selected antibiotics should be able to penetrate the biofilms and endothelial barriers to act on the targets. That is very important. Second point is variability in the drug response. This is very common. It may vary from person to person or even in the same person at different occasions. So that leads to variability in the drug levels. This variability may be due to some genetic variability among different population, or it may be variability due to weight. Over a patient, they restrict the normal or equal level of the drug in the body. They may produce variability in the different tissues. Or similarly, height, age, other comorbid conditions including renal and liver dysfunction, or even drug interaction. That is also very important, as we discussed in the drug interaction while we discussed the general pharmacology. So that requires the better dose adjustment. There may be switching therapy, some to another choice, or they may require changing the concomitant medication, etc. Now, selection also depends upon susceptibility testing and selection of antibiotic agent. Usually there is dilution test. Now these dilution tests are, there is a serially diluted concentration in a culture of the test microorganism. Here this diagrammatically, antimicrobial concentrations for organism substance present from right lowest antibiotic concentration to the left highest concentration, that is 0.5 to 64. This is the relative antibiotic concentration containing tubes. Here the organism may be inoculated and we check the growth of microorganism. Now growth of microorganism is measured usually after 24 hours of incubation. From here we calculate the minimum inhibitory concentration, MIC abbreviation is used for that. So actually this is the lowest concentration that just inhibits the bacterial growth after 24 hours. In this diagram we see in the first two concentration 0.5 and at 1 there is bacterial growth, but when the concentration is at 2 times, MIC is the lowest concentration, that is here equal 2. So 2 is the minimum concentration, lowest concentration that has inhibited the bacterial growth after 24 hours. Here the MIC will be at the level 2. It may be 2 microgram or 2 whatever, so it's just an indication. Then selection of dosage and dosing schedule also depends upon the minimum bacterial concentration, MBC. So actually that is the antimicrobial concentration that kills the 99.9% of bacteria. For example, here in this diagram, this is equal to 32. Before that, up to 16, we still see the bacterial growth. Obviously in the 16, the lowest growth is seen and the highest at the level of 0.5. But at the level of 32, then there is no up to 99.9% bacteria have been killed. This is the minimum bactericidal concentration, MBC. Now, what are the types and the goals of antimicrobial therapy? It may be just prophylactic. Prophylactically, we use these antimicrobials when there is no infection. For example, pre-surgical or post-surgical, or HIV patients, or AIDS patients, or anti-malarial person going to some endemic area where malaria is very common, traveling to that area. So prior to that, patient is advised to take antimalarial. Similarly, these prophylactic use of all these antibacterial, antiparasitic, etc., is given. Then preemptive. This preemptive use is when there is impending infection. For example, some post-organ transplant, when we are usually using immunosuppressant agent, due to decreased immunity, there may be or there are strong chances of growth of bacteria or fungi, etc. So, to avoid that, we are using antibacterial or antifungal, etc., etc. This is the preemptive use. Third is the empiric. That is unique when symptom of the infections appear. For example, simple may be fever or maybe sore throat, etc. So, we don't know, okay, what is the type of microorganism. We may just know the site of an infection also. So, here, prior to get any proper culture sensitivity test, etc., identification of the proper bacteria, we can start using broad spectrum antimicrobial. But remember, first of all, we get the sample which we are going to the lab for culture sensitivity. Then we start these broad spectrum antibiotics. Otherwise, there may not be any growth seen in the culture. There may be false result, or we can face some difficulty in selection of the specific drugs. Fourth one, definite specific antimicrobial agents. This is started when the proper specific pathogen isolation has been done after culture sensitivity. Now we can be very targeted. Now we can select which is narrow spectrum, very specific antimicrobial agent we can use. And now even we can start with the monotherapy. And lastly, suppressive. This is usually post-treatment. Okay. We have completed the treatment with the antimicrobial, what we have seen, still complete eradication has not seen. So for the complete eradication, we can continue the use of those antimicrobial agents, that is known as suppressive use. So these are different types of 5 types of antimicrobial uses. First, empiric therapy, we can see the possible use of antimicrobial agents in the proposed types of bacteria. For example, bacterial endocarditis, some specific microorganism Staphylococcus aureus or viridans streptococci or enterococci may be there. In the first column, there is selection of the first choice of the group. For example, here, first choice is vancomycin, ceftriaxone. We will see later on what these names are, to which these drugs belong. Ceftriaxone usually it is the third generation cephalosporin. Anyhow, this first column is the first choice. Second is the then second choice, penicillin resistant penicillin and gentamicin. This is the acute bacterial endocarditis. Similarly, subacute bacterial endocarditis. Here, viridans are streptococci and enterococci. Here, the combination of penicillin and gentamicin, first choice. Second is the vancomycin, gentamicin. So, in this way, all other different types of infection, septic arthritis, both in children and adults, we have first and second choice. Specific bacteria we have written here, which are responsible for the production of these infections of septic arthritis. Similarly, acute otitis media, infection of the inner ear, or there may be sinusitis, bacteria, Haemophilus influenza, Streptococcus, etc. Amoxicillin is the first choice, second other. Similarly, cellulitis, subcutaneous infection is there. So, Streptococcus aureus or group A Streptococci, etc. Similarly, first and second choice drugs are given here. And there may be meningitis in the neonates, in the child, or in the adult. All are responsible for the different types of bacteria given here. And also the first and the second choice accordingly. What is the first choice in neonate, in the children, in the adult, and second choice in neonate, children, and the adults. Similarly, peritonitis due to rupture viscera. It may be rupture ulcer of the stomach or some other problem. Maybe there is a rupture of the viscus of the stomach, of the intestine, or large intestine, etc., etc. So, pathogens may be coliform bacteroides, etc. Similarly, first choice metronidazole. We will see later on what actually the metronidazole, antimebic, commonly we can get it under the name of flagell. So, cephalosporin, etc. Then the second choice. Then the pneumonia in the neonate. Here, all the microorganisms and the first and the second choice are same as we have seen previously in the neonatal meningitis. Similarly, in children and adult. In children specifically, again specific microorganisms, pneumococci, etc. Then the first choice, ceftriaxone, etc. Then the ampicillin bacterium, second choice. In the adult, usually community acquired infection is there in the pneumonia, in specific barracks, in the hostels and other wards, etc. The patient is taking infection from other patients. Here, usually pneumococci, mycoplasma, legionella, etc., etc. These are usually seen in the outpatient department. First choice, macrolides, amoxicillin, tetracycline. Second choice, quinolones. But these may be in inpatient also, who are admitted in the wards in the hospital. So, first and second choice are given here. So, these are the possible site of infection accordingly. We can start using the drugs under the heading of first choice usually. Similarly, septicemia antibacterial can cause, or septicemia with granulocytopenia. Granulocyte count is reduced, so immunity is reduced. So, any type of bacteria can produce septicemia. So, accordingly, we have given the drugs which are useful against septicemia with or without granulocytopenia.